You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast with myself and Walker. In this session, we're looking at thoracotomy with Zane Perkins. So what I wanted to do is dig into the latest research that's emerged from a trial which both Zane and Mike Christian have led around thoracotomy in the UK. So the researchers examined over 600 retrospective cases from London and looking at a database spanning over 20 years, looking at the survivors and indeed the mortality, the pathology, looking at pre-arrest rhythms and the morbidity and mortality. Also looking at time of intervention versus outcome, as well as other markers. So what I wanted to do is explore this research and the potential implications on practice. So Zane Perkins is a consultant in trauma and general surgery at the Royal London Hospital. He's also a consultant physician for London's Air Ambulance in Whitechapel, London. He's also an honorary senior lecturer at the Centre for Trauma Sciences at Queen Mary's University in London. So welcome to the podcast, Zane.
Thanks, Owen. It's great to chat to you again. It's been a long time.
It's good to have you on the podcast. So Zane, I just wondered if we could first kick off by just if you could just speak to your current thinking on thoracotomy practice and why you decided to undertake this research.
Yeah. Well, so London's Air Ambulance has been doing thoracotomies for a long time. From the early 1990s, and they've had survivors all through, so it clearly works for some patients, and they've been honing the procedure and working on trying to figure out exactly what patients, what are the indications and what patient groups it works in. And this has kind of been happening quite separate to what the rest of the world does. It hasn't caught on. It's been nearly 30 years now since London had their first survivor from a thoracotomy, and it's not really ingrained into practice. So we wanted to have a good look. Last year, the European Resuscitation Council put out new guidelines on the management of traumatic cardiac arrest, and even in there, they acknowledged that in the whole world literature, there's only actually about 280 cases of pre-hospital resuscitative thoracotomy described. And it's very hard with such a small literature base to really understand something and when it should be used. So clearly there's lots of unknowns and what ifs and controversies. And we knew we had a much bigger, data set of this procedure, and then that would allow us to actually answer a lot of these questions. So that's kind of the reason behind it.
So looking at the study, Zane, in the primary and secondary outcomes, could you maybe speak to what you were interested in examining and indeed maybe bringing to light from both the survivors and or indeed the mortality?
Yeah, for sure. So clearly, right from the start, and this was Mike saw this straight from the beginning, is traumatic cardiac arrest is a relatively common cause of cardiac arrest, but obviously it's all dwarfed by medical cardiac arrest. That's your biggest cause of cardiac arrest. And if you compare how we manage traumatic cardiac arrest to how medical cardiac arrest is managed, not in the interventions you do, but just it's very clear how to manage a medical cardiac arrest. The guidelines have been going for a long time. They're constantly improving, but there's very clear guidance. People are trained up in them. Clinicians know what they're meant to do and why they're doing it. Whereas that's not the case in traumatic cardiac arrest. It's very unclear what the optimal treatment pathway is. And that means people are doing it different everywhere, and then they're getting different outcomes. And, so we wanted to follow the lead of how the medical side had got to where it had gotten to. And one of the things they've done is they've organized their research so that it can be comparable. So, when people are doing research in different places, and that you can start actually comparing it. And there were some guidelines, the Utstein guidelines saying, if you're doing research on medical cardiac arrest, this is how you should present your results and the kind of data points you should be trying to collect. So we followed that kind of guidance as much as we can. There are some subtle, well, there's not some subtle, there's some differences between trauma and medical cardiac arrest, but we try to follow that as much as we could. So for outcomes, we followed the Utstein guidelines, and essentially what that looks at is survival to hospital discharge, and survival at 3 months, and survival at 6 months. And then of your survivors, also how neurologically intact they were. And there's a number of different scoring systems or classification systems for that. The one we used was the cerebral performance category. It's nice and simple, so you can easily do it going prospectively, but also quite straightforward to do it going retrospectively. And we use that score to divide people simply into two groups, like good neurological outcome and poor neurological outcome. And then, so that's all your survivors. And then obviously when you're looking at traumatic cardiac arrest, the majority of people don't survive, but we wanted to look at those that got a meaningful ROSC. So, and across both, and these are the kind of things that everyone could define this differently, but what's been standardized in the Utstein guidelines is if you survive the event of the cardiac arrest would be if you got a good ROSC and you managed to get that patient to hospital and hand over that patient to the hospital team to take over with a good ROSC. But then they might have died maybe the same day, next day, or a week or a month later, doesn't matter, but they died in the hospital. So that was one of our outcomes as well, is survived the event, meaning you had a good ROSC. And then we just, everything else was died on scene then. So if you never got a ROSC, or you got a little ROSC that then faded away, or if you tried to, if you took someone to hospital but never had a ROSC, you took them in arrest to hospital and then they're just declared dead in the hospital. So there's so many of these things. If you try and report it all, it just makes it all muddy and messy. So we just said, look, if you never got a ROSC, or if you just had a little ROSC but then still never left the scene without a ROSC, then you essentially you had died on scene. It was just a matter of not pronouncing the life extinct maybe at the scene, but you had actually died on the scene. So that was our last outcome. And then that made things a lot more, simple. So, we had three categories. Either you survived to hospital discharge, or you survived your event but died in hospital, or you died on the scene.
I think that's essential as well, like you said, just actually being distinctive and indeed clear around outcomes. So there's also then clear possible proof of benefit, and retrospectively looking, and there's clear segmentation when you look back at cases, so you can start to delineate the trend and indeed the intervention. So just talking about the sort of the intervention itself, when you look at these cases, what was emerging from the survival rates, Zane, in your mind? So who were the majority of the survivors when you look back at these cases?
Yeah, and this is an interesting question. So I'm going to be a bit roundabout in how I answer it, but I think it's important. So, like I said, there's very little literature on pre-hospital resuscitative thoracotomy, and one of the things I wanted to do right at the beginning was move our service and use this research to move it on from trying to always talk about an intervention and then trying to fit patients to your intervention, to actually trying to talk about the problem that the patient has, so the pathophysiology that they've got, because there might be more than one intervention for that disease that's going on, and the clinician should rather think about what the patient has and what they're able to do to treat them. And and I'm sure many services around the world, we try and shoehorn people in. So we've got a thoracotomy SOP. So we're trying to fit someone into that SOP, or we got the Reboa SOP. So then it's trying to fit them in there. And rather than talking about we've got an exsanguinating patient, or we've got a patient with cardiac tamponade, or we've got someone with a tension pneumothorax, and then knowing, what needs to be done and what your goals in treatment are to achieve that. So that was the one issue that we had, and we wanted to use this research to try and move in that direction. And the second was the research that had been done before, probably because it's easy, had always divided groups into blunt and penetrating trauma, and therefore always analyzed outcomes and everything according to blunt and penetrating. And clearly things are different with blunt and penetrating, but if you look at again, cancers or other diseases, they don't divide the diseases by the risk factor for that disease. Okay, so you don't hear people saying, oh, smokers with cancer, we treat them like this, and non-smokers with cancer, we treat them like that. You hear them talking about the answers. This is a colon cancer, or this is an esophageal cancer, or this is a lung cancer. Yeah, some of them might have smoked, some of them might not have smoked, but it's the disease that is the problem, not the risk factor for the disease. And that's the same with trauma. The way you injured is the risk factor for the injury that you sustain and what happens after that. So people who've had blunt trauma are far more likely to be bleeding, and far more likely to be bleeding from multiple sites. Whereas people with a penetrating trauma would be far more likely to get something like a cardiac tamponade, far more likely to have an injury to a major artery. Arteries are elastic, and if you hit with something sharp, they will open up. But if you hit with something blunt, they tend to just stretch and not open up. So, so you got a different kind of hemorrhage as well, much more fierce, but only from one spot, if you know what I mean, with penetrating. So, and because you're getting different diseases, you have different outcomes. But I suppose from when you doing the research, it's very easy to classify them into blunt and penetrating, because sometimes you don't know what was wrong with them. You don't have the forensics or the so right from the beginning, relatively near the beginning, we had discussions about this, and we decided we'd rather look at our data set, because we knew it was going to be big. It was going to be more than twice the size of all the data that's out there, to try and end that kind of dichotomy in its tracks and actually try and have a look at what was the problem with these patients, divide them up that way, and then look at outcomes so we can better understand it. So getting back to your question, so we divided people up into actually what was wrong with them, and then looked at the outcomes. You asked then about how they did, what the outcomes were. So what we found really was probably, by far the most important finding in the whole thing is the majority of patients, like all but 6 out of 600 patients, okay, so had either tamponade or exsanguination, as you would expect. That's the kind of 2 diseases you are trying to use a thoracotomy for. And as you well know, with our procedure, the kind of very first step we do is bilateral thoracostomies to try and exclude a tension pneumothorax. So if someone had a tension pneumothorax, they usually wouldn't progress on to a thoracotomy because you would relieve it. So in the 600, almost everyone was either exsanguinated, tamponade, or both. There was a group of patients who had both bled and had a tamponade. And the 6 that didn't have those things, there were 3 or 4, I think, that we couldn't clearly say what was going on. They were probably exsanguination as well, but we couldn't properly say. So that was just a very small group who are unclear, way less than 1%. And then there were a few, as you'd expect, people have been stabbed. There was a major airway injury, and one of the blunt trauma patients had actually had a big myocardial contusion that had put him into VF. So, but these are tiny numbers, less than 1% of the whole data set that had either bleeding or tamponade. And then what we found was the patients that had tamponade did very well by all kinds of measures of what you would expect someone who's in cardiac arrest to do. So they did very well if you relieved the tamponade. Exsanguination patients, we had survivors, but it was tenfold less survivors if your reason you had an arrest was exsanguination than if it was tamponade.
So Zane, sort of looking at that, really, myself and you have been to plenty of cases where we've done thoracotomies on various pathologies, but sort of looking at sort of the pre-arrest rhythms for these patients, for these two subgroups, because it is useful, like you said, to separate out the metadomains and indeed the subdomains. So there's these two clear differential sort of diseases. Could you see any sort of succinct differences in pre-arrest rhythms that you saw, and indeed has that sort of led to any different thinking as far as decision making, either to do the intervention or indeed around outcome?
Yes, essentially. So this group of patients, you're arriving to them at different stages in the disease process. So what we wanted to understand was, what are the kind of rhythm. So from a physiology point of view, all these reversible causes of cardiac arrest, well, with certainly tamponade and hemorrhage, at the crux of it, they're causing reduced coronary blood flow, and then your whole heart is landing up not having oxygen delivered to it. And we kind of know from children that if that happens, if a child is hypoxic, the heart, which would initially be tachycardic, will then brady down, and then the complexes then start widening because the septum and the sinoatrial node in that is then hypoxic, so it widens, and then it will degenerate, flatten out into asystole. And we don't really see like VF in that. Those are usually like a very irritable myocardium where you've blocked a coronary artery and just a piece is now ischemic. So we had a look to see if that was the case, because we knew in actually a very big portion of these patients how long they'd been in arrest. It took a long time, but the nice thing with our data set is all along London HEMS, you fill in a run sheet in real time that's handed over to the hospital, and we've, as you well know, we audit that every single box on that run sheet is filled in. So you've got like 100% complete records on all these cases, and then the clinicians come back and write more detail on those in a database. So you've got all that data as well. We photocopy the ECG rhythm strips, either from the ambulance service or ours. So we have all of that data as well. And then clinicians in all the thoracotomies, because it's not something you do every day. Actually, this data set, it's big. We've done 600 thoracotomies, but in the same time, we've seen 46,000 patients. So like, it's less than 1 in 100 patients on London HEMS that gets a thoracotomy. So it's a relatively rare occurrence for the clinicians to be doing it. And all of them would still write a free text in real time notes on the procedure, on why they did it, about the timings, about the indications, and about the actual procedure that they did. So we had a really rich data set. And the other area that was really helpful is the HEMS paramedic dispatching the aircraft is also on London HEMS, is also one of the paramedics who works on the aircraft, and they would be keeping a note in the ambulance service. So they often would know, when the police arrived, when the first ambulance crew got there, and often when the patient arrested. If they found out, they would document that time, and we got those records as well. So we had really good timing records. I must say another thing that was really helpful is just something that is always done on London HEMS is all the dispatches are coming from one place, from the London Ambulance Service, which obviously has a clock. So all the times are standardized. And every morning on London HEMS, we check that the clocks on the monitors are matched up to that London Ambulance Service clock. So all our times are all the same. So you can compare records from the monitor printout or to what people were recording in the dispatch room, and you know that those times are the same, and then you can work out. So we were able to work out for most patients, like probably 90% of them, when they actually went into arrest and when the team got there. So we knew how long they'd been in arrest for, and then obviously when the team got there, we could see because they printed it out, or what they've documented as to what the rhythm was when they got there. And then from that, when you've got a big data set, you can start seeing the picture of what rhythms are people in if you witness their arrest, if they arrest in front of you, what rhythms are they in if you get there 2 minutes, 3 minutes, 4 minutes later, 10 minutes later, 20 minutes later. And we very clearly in our data could see that the same thing was happening as happens to hypoxic children. So they would be tachycardic for some time, and then they would lose consciousness, become unconscious, they're going to arrest, pulseless, and then they'd be tachycardic for a few minutes after that, and then the heart would start slowing down. Not in seconds, it would take a few minutes to slow down. So going through a relative bradycardia, and then going into a proper bradycardia, under 50 beats per minute, and then start widening and then degenerating to asystole. And we didn't actually see any VFs in all 600 of these patients, except for the patient who had the blunt cardiac contusion. That's not to say we didn't see VF. So we often saw VF during the resuscitations. So if people have been, getting internal massage or given some adrenaline, and just in the process of trying to resuscitate a heart, often it would, when it's starting to try and come back to life, the first rhythm might be VF, and then you shock that, and then they get back into a actual sinus rhythm. So those are the kind of rhythms we saw, and that fits with the physiology, and that was good because it kind of validates your data set, that it's marrying up to what you'd expect to see. And then you're saying what was the use of that, is then we could also see what outcomes were for these different rhythms. So we had looked at our outcomes according to how long someone had been in arrest, and there's a very, very clear correlation to that. So as we know from medical cardiology, it's incredibly time-sensitive disease. For every minute that you're in cardiac arrest, you're losing about a 10% chance of survival. And there's, even on the medical side, there's usually, rarely survivors after being in arrest for 10 minutes. And we saw the same thing, that it would just be a rapid decline with time. So then we knew that the patients were, correlated with time, and then we knew that the rhythms were correlated with time as well, how they degenerate then. So we had to look at whether you could predict your outcome from the rhythm you were in, and it was very clear again. So if you were in a sinus rhythm, it meant you'd probably been, sinus tachycardia or sinus rhythm, that you'd only been in arrest for a few minutes, and you had very high outcomes, like 60% or so. If you were bradycardic but still in a narrow complex, you've been in arrest for 5 or so minutes, and your outcome would have dropped down to about 30%. If you're in a wide complex unorganized rhythm, then you'd probably be closing in now on 10 minutes of arrest, and you'd have a much lower survival there. And then once you're in asystole, was actually a marker that you'd been in cardiac arrest for quite some time, and very poor outcomes from that. So, as you know, a really difficult decision when you arrive on scene to someone who's already arrested, to know whether they're within the window to have a survivor. But we felt the ECG could be, a useful little tool for that, and that's why we explored it.
So Zane, that's fascinating information, actually, and a couple of sort of things come out of that, actually. A couple of questions, and I think I'll ask them sort of sequentially. One would be around I guess, does that change decision making according to time? So just seeing the trend through the data, does that maybe in your mind, or indeed the whole team's mind, extend the window of time for certain disease pathology? And I'll get the second question out, but I can come back to it because I'll probably forget it if I don't, but is around, and it's a very difficult question around, does this mean actually we need to consider pre-arrest intervention, so pre-arrest thoracotomy in the peri-arrest patient, which again is it's a difficult question to ask. It's also a difficult intervention to enact when the patient hasn't arrested, but maybe the leverage and chance of survival is within that window if you are lucky enough to be on scene at that time. Sorry, that's a lot of questions, but maybe
yeah. I'll actually tackle your second one first, because I think it leads on better to the second one. So that whole idea of peri-arrest and arrest is important in traumatic cardiac arrest, because okay, so in a medical cardiac arrest, it's very clear when the person arrests, because your rhythm changes. You know, 1 minute you're in sinus rhythm, awake and talking, and then your heart goes into VF and you got no output, so you very rapidly lose consciousness after that. But it's a very clear point in time when that rhythm started, or you go into ventricular tachycardia or whatever. That's not the case in traumatic cardiac arrest, because you're going through this process of basically landing up with no coronary perfusion because of the process that's going on, and then a heart that can manage to keep going even though it's hypoxic. So it's basically, you know, anaerobically managing just to keep beating along for a bit, but it's not sufficient to generate any kind of output. So the output's going to like super low, but still a little bit of output, and then, you know, degenerating. And then once there's no proper output, then the ECG starts following in that process. So I think it's important to define traumatic cardiac arrest, you know, the same way across the world. And I'm not sure that's really been done exactly yet, but for me, and a lot of the papers and that do describe it, if someone is unresponsive, so unresponsive to pains, and you know, obviously not someone with a big head injury, but someone who's unresponsive because of a lack of perfusion, and you can't palpate any kind of output or measure. So there's no blood pressure measurement, you can't feel a central pulse, and they are totally unconscious, no movement, no response to any kind of pain. That person is in traumatic cardiac arrest. Or we should probably call it traumatic arrest, because cardiac arrest means the heart has stopped. Clearly, it might not have stopped, but it can't generate any kind of output that you can feel, and it can't generate any kind of output that allows the brain to work. So there's no function coming from, no, you know, it's totally unresponsive. So for me, that is what traumatic cardiac arrest is. And clearly within traumatic cardiac arrest, and you've got this super low flow state patients where the heart is actually still got an organized kind of, you know, beat to it. And you might see that as a narrow complex ECG, or you might see that on your ultrasound as a, you know, organized beats, and then that degenerating to when, you know, an unorganized electrical activity, or basically seeing some really feeble flickers or nothing on ultrasound. All of those are what we call at the moment pulseless electrical activity. And I find that a really unhelpful term, because it covers such a range of what could be happening. And it's important because depending whether that's a sinus rhythm or a wide complex rhythm dictates your, not dictates, but, you know, the outcomes are so different between those two groups. So yeah, so I think the definition of traumatic cardiac arrest is important. And within that, you know, some of it is low flow with a heart that hasn't actually stopped yet, and then those that the heart has stopped. Then you said the first question was about the time window, and as you quite rightly said, we looked at this time window for the different diseases, so exsanguination, cardiac tamponade, and actually the group with both the cardiac tamponade and what we found was for cardiac tamponades, the window for good survival was 10 minutes. Like, so within the first 10 minutes, we had a lot of people who had survivors fully neurologically intact. From 10 to 15 minutes, we had a few more survivors, but they invariably had neurological deficits. And we didn't have any survivors after 15 minutes. So the window is, 10 to 15 minutes after cardiac tamponade. And good levels of survival, like overall, like if you just take 10 minutes, so if we looked at all of our cardiac tamponades who had a thoracotomy within 10 minutes, the overall survival in that group is 40%. So nearly half of them would survive if you did it in 10 minutes. And actually in all comers, and some of them, people are, as we know, that the decision to do it is very difficult, can be. And you might get told that the person had some signs of life 5 minutes ago, so you do it, and then when you look at everything once it's all over, you realize actually they might have been in arrest for 30 minutes or 40 minutes away. So there are those cases in our data set, but even all comers for cardiac tamponade, our overall survival was 21%. So really high. If you think this is cardiac arrest and you compare it to like out of hospital medical cardiac arrest, like those kind of numbers are like very good survival rates. So it's a decent window, I think, for cardiac tamponade. Now, that's very different for the exsanguinators. So we never had any survivors after 5 minutes of cardiac arrest from exsanguination. And I won't go into it, but it makes quite a lot of sense because in tamponade, a healthy heart has almost been forced to stop, but in exsanguination, it's just like, used up every last ounce of energy it's got until it finally stops. And then when it does that last beat that it can possibly put out, that will be his last beat. It's just impossible to get that heart to start again because it's spent everything. So invariably, the only survivors we had from exsanguination was the patient arresting in front of the team who are already actually trying to treat that patient. So they knew the patient was severely shocked. They already had lines in. They were trying to treat them, and then they arrested and they did a thoracotomy intervention, whatever, and then they managed to get them back immediately. But so the window to act is tiny for exsanguination. Essentially, is just if you witness it.
So just as we're coming into land in the conversation, a couple more questions, Zane. Just one would be around sort of the way in which maybe SOPs, standard operating procedures, might then be written, and just prospective decision making really around our approach to the differential of disease. So the tamponades versus exsanguinators. Could you see, and it's maybe hard to go into the weeds, and maybe that's probably not the place to be, but can you see there being a shift in SOP and or approach based on pathology pattern, based on time, and maybe consideration to pre-arrest rhythm, or maybe triangulation of all three?
Yes, I think when you've got data, you can be much clearer in making SOPs and that. So certainly, so for the tamponades and the SOPs fit with actually the guidance that came out last year. So the European Resuscitation Council guidance is very clear that the treatment of traumatic peri-arrest and cardiac arrest is different to the treatment of medical cardiac arrest. And I think that's really important up front. And then the second thing that they are very clear on that's really important is that the primary goal of treatment of traumatic cardiac arrest must be the treatment of the cause. So they're even saying people must be aware of why they think this person's in arrest, and they must go straight for that. And that takes priority over all other measures. So priority over CPR, priority over so, and as we know, there's only 4 major reversible causes, hypoxia, tension, pneumothorax, hemorrhage, and cardiac tamponade. And that's, I think those are the two real key points there. So if we're going to say that if you've got a traumatic cardiac arrest, you must go straight for treating the cause, what's clear in this data is for tamponades, and they're not that common, depending on, but they still make up about 10 to 15% of your arrests, is you want to identify the tamponades and you want to treat them because they have a very good chance of survival. And there essentially is only one treatment, and that is a thoracotomy. If you're in a system that can deliver that and get to that patient in time. So I think that's quite clear. There's not much controversy there. If you can't, obviously you can't just go out and try out a thoracotomy. You need to be trained and have the right equipment and everything. So, but if your system doesn't have that, then people with that disease can't survive. So that's quite clear. What isn't clear then is what we should do with the bleeding ones. And I'll come back to, so the other important thing with the tamponades then that you want in your SOP is how do you identify them? Because you don't want to not, if you're in a system that can offer thoracotomy, you don't want to not offer someone who lands up having one something that would be very effective. And what we did find in the data that all the tamponades, so we had tamponades with blunt trauma and we had tamponades with penetrating trauma. But the penetrating trauma ones, as you would expect, but it's good to see it in the data, all had a penetrating injury either to their chest or the epigastrium. So there weren't any stabs anywhere else. I suppose if you're in a system with a lot of gunshot wounds, it's possible. But we found that if you'd been stabbed in your chest or epigastrium, about 40% of patients would have a cardiac tamponade and about 60% would be bleeding. So that's a really high proportion just based on the mechanism there, if the stab wound's in the right place. So we would then suggest, that you just treat them as if they were a tamponade there, because give them the benefit of the doubt. There's a 40% chance it's there. If it's there and you're there within the window, they can have a really high, even if you do it with, soon after arrest, even more than a 50-50 chance of survival. So then exsanguinations on the other hand, I think we need to think a little bit harder about how we treat them. And I don't think it's very clear on what the optimal treatment is. I think what is clear from our data is that the best thing is to avoid them fully arresting, because what's clear is once that heart stops in exsanguination, then the game is over. So we should do everything we can to stop that. So you want to catch them in that peri-arrest phase. What was very clear in our data set is we had no survivors from asystole. So that's helpful in decision making. If you know that it's hemorrhage, so it's not a stab wound to the chest or whatever, it's a stab wound to the groin or to the neck or something, and they're in asystole. It doesn't matter how long someone said they, if they saw movement 5 minutes ago, they're not within the window. That's a non-survivable injury, and you could not start that procedure. We had a look at our data set to see, just closely look at the exsanguinators who survived to see what might be working. And that had some clear lessons as well. So all the survivors had aortic occlusion, and all of them had quite high volume resuscitations. Well, say quite high volume, they basically get given everything that HEMS carries. So whether it be 4 units of packed cells or 2 units of whole blood or 2 or 3 liters of crystalloid back in the old days, but they basically had everything with volume emptied into these patients with an occluded aorta. And all of them had a beating heart when they did it. So although they were pulseless, the heart itself was trying to beat. And that makes sense, because that's how you re-establish coronary perfusion, is they need the volume, keep the volume up in that top half of the body so it goes back down into the coronaries. So we kind of probably want to aim going forward at emulating that, is trying to catch the exsanguinators before they arrest, and then being able to, carry the volume that they might need. So I think that all of them would have needed more than what we gave, that they just got everything that we had. So we might have more survivors if we have more volume. That's difficult to do, but I think we should try. And now on London HEMS, we do carry more than 4 units. We're carrying, usually each vehicle will have about 8 units of blood on them. And if you think someone's going to arrest, preempting it, if they're pulseless and you've still got a narrow complex rhythm, you should try and occlude that aorta quickly, because you know that within a few minutes it's going to degenerate to a wide complex and then stop. And that can be done in 2 ways. It can be done via thoracotomy, or can be done by REBOA. REBOA takes some time to do. So if you were with this patient all along and they were quite badly shocked, you might want to think then about, if this patient gets worse, I'm going to be in this peri-arrest situation. So maybe now's a good time to put an A-line in. If they got worse, then it only takes a minute to do a REBOA. So you're 1 step ahead. But if you haven't even put an A-line in, then and they're already like slowing down, then the fastest way to occlude the aorta is going to be surgically. But it doesn't need to be the whole procedure that we do for tamponade, because you don't need to open the pericardium, because there's not, if you're sure that it's exsanguination, then you don't, those steps are just delaying you from doing. So you could just go from the left, like a big thoracostomy on the left, put your hand in and occlude the aorta. And these are really, steps just to try and avoid a full cardiac arrest. So yeah, I think that's where we'll be looking a little bit more closely going forward, and try and see what's the optimal way for these patients for the exsanguinators. It's important, because exsanguinators are by far, in any system, will be the majority. In our system, it's about 80% of all the cardiac arrests are from exsanguination. So we really need to, understand it better and get clearer what's the optimal treatment for that group.
And it's really nice, actually, Zane, to hear that there potentially is more tools in the toolkit for these patients, like you said, because not only do they need to be caught early, but they need aggressive treatment once they are caught early, and maybe multimodal treatment. So yeah, good oxygenation, good refilling, but that good tamponade at point of as close to point of injury as possible. Listen, that's fantastic, Zane. I think what we'll do is bring it into land there, if that's okay, just for the process of time. But I would love to have another conversation with you, indeed, maybe about some of the other trials that you guys are kicking off at the London in the next few weeks. But then what I'll do is, we'll check in again and have another conversation about some of the maybe blood trials and otherwise. But I just want to say thank you for the last hour and for your perspectives.
Anytime, Owen.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.